or dynamic. One thing is clear from the first 3-4 things is that there is obstruction which is causing a low aortic pressure compared to the LV systolic pressure. Now, this PVC came. What happened with this PVC? The PVC causes low LV stroke volume. Because of the low LV stroke volume, there is compensatory hemodynamic response and there is reduction in the systemic vascular resistance, leading to low diastolic aortic pressure. Aortic diastolic pressure is decreasing. Aortic diastolic pressure is decreasing, and in the subsequent beat after the ectopic beat, the aortic pressure is going, systolic pressure is going back to normal. The diastolic pressure is low because of the decreased SVR. So we are having a good pulse pressure. Here the pulse pressure is this much, and here the pulse pressure is increased. So we are having a post-ectopic increase in the pulse. Similar, but we are having a good pulse pressure after the ectopic. So whenever the pulse pressure is increasing after the ectopic beat, it is a fixed obstruction. I hope I am clear.
Yeah, dear friends, do write whatever sir is saying. I mean, you can keep typing it also, that, so that for those who are unable to, those who are in the newer first year or something like that, they are able to understand it. Because I want every one of you is equally important and most important. Okay, Dr. Ankit very nicely explained, I must say.
So again, to revise you, why? Because in exam, you will always answer this is a fixed obstruction. But if they ask you why the pulse pressure increases, I hope I, almost 9 out of 10 will not able to answer why it increases. You remember this mechanism. So increase in pulse pressure is because of the low diastolic pressure, because of the decrease in SVR. Why there is a decrease in SVR? Ectopic beat causes poor LV stroke volume in that beat, ectopic beat. Because ectopic beat is coming early, LV is getting less time to get filled. So there is a poor LV stroke volume. Because of the poor LV stroke volume, there is acute hemodynamic autoregulation, which causes decrease in SVR and causes low aortic diastolic pressure. Now coming to this phrase, almost similar to the previous one. So now you are answering it is HOCM, and or you are answering it is a dynamic obstruction. Can anybody tell me why here the pulse pressure is decreasing? In the previous case, the pulse pressure was increasing. Why here it is decreasing, and why the gradient is increasing? Can you type the reasons for it? So half of the mechanism somebody has written. So half of the mechanism we have seen in the previous case. In this beat, there is a decreased LV stroke volume, compensatory hemodynamic response, leading to the decreased SVR, leading to the low aortic diastolic pressure. Now, in HCM, the gradient or the dynamic obstruction depends on two things. One is the LV contractility, and the other thing is SVR. So here both mechanisms are happening. First, because of the post-ectopic beat, now this will have a increased LV contractility because of the Frank-Starling law, because of this compensatory pause, this beat will have a more LV stroke volume, more LV contractility because of Frank-Starling law. So here the contractility is increased. Also, on top of that, the SVR has decreased. So both these mechanisms are causing a very exponential increase in the LV systolic pressure and increased gradient leading to the low aortic systolic pressure. So although the diastolic pressure is going down, but the systolic pressure is also going down very much. So we are having a low pulse pressure, exponential increase in the gradient, and this is characteristic of the dynamic obstruction of the HCM. The two mechanisms are happening simultaneously, decrease in the SVR and increase in the LV outflow obstruction because of the increased LV contractility. I hope I am clear. If there is any doubt, you can ask again. So again, this thing, decrease in the SVR and increase in the LV contractility, both are contributing to the worsening of LV outflow obstruction, leading to exponential increase in the systolic pressure of LV and fall in the aortic systolic pressure. Okay. What pressure is being recorded here? Okay, and diastolic pressure. Now, just tell me 1, 2, 3, 4 arrows are there. Which arrow should I take? First arrow, second arrow, third arrow, fourth arrow. Which pressure should I take? Should I take the first one, the fourth one, or average of all? All are at the peak of R wave. All are at the peak of R wave. All are at the peak of R wave. So which? Somebody is saying third. Okay. Shivans has written the correct answer. Whichever is the highest. So we have to take the highest LVEDP because LVEDP has got a prognostic significance. We have to take the highest LVEDP, or if we are I'm also recording simultaneous the inspiration and the expiration, then we have to take the end expiration. So either if you have not measuring the respiration, then you have to take the highest pressure, or you have to take at the end expiration. So now my question is, suppose this patient is intubated or on mechanical ventilation, then at what respiratory phase you will take the LVEDP? So
Reason also.
reason also, as sir has correctly pointed out, then only you will remember, otherwise you
Yes.
will get confused in the exam.
Yes.
So in a normal human being, all pressure decreases with inspiration. All pressures decreases with inspiration because of the decrease in the intrathoracic pressure. These intrathoracic pressures are transmitted to the intracardiac pressures, and RA pressure, RV pressures, LA pressure, LV pressures, everything will decrease with inspiration. These pressures are highest at end expiration. So in a normal person, the LVEDP is measured at end expiration. When we are giving positive pressure from outside in form of mechanical ventilation, the pressures will be highest at end expiration, end inspiration. When we are giving a positive pressure from outside, the pressure will be high at end of the inspiration. So in a positive pressure ventilated patient, we have to measure LVEDP at end of inspiration. In a normal person at end of expiration. Remember this thing. So identify this trace. Okay, somebody is telling it is, you have to write some findings. Very low aortic diastolic pressure. Very good. Equals to aortic LVEDP equals to aortic diastolic pressure. Very good answer somebody has written. So here, probably this is a trace where aortic valve intervention was done, and post aortic valve intervention something happened. Now here the yellow one is the LV pressure trace and the red one is the aortic pressure trace. Here the systolic pressure of LV and aorta are equal. So there is no systolic gradient. However, when we going from the peak of the R wave and drawing a line here, so this is the LV end diastolic pressure, and the aortic diastolic pressure and the LV end diastolic pressure are almost equal. And aortic diastolic pressure is around 30 mm of Hg, and the LVEDP is also around 30 mm of Hg. What is normal LVEDP? So it is up to 12 mm of Hg. So it is almost 3 times of the normal. So LVEDP is markedly increased and aortic diastolic pressure is markedly decreased with a wide pulse pressure. So probably this is a acute aortic regurgitation. So we have to mention in the exam, there is an equalization of the aortic diastolic pressure and the LV end diastolic pressure. What happens if this trace is taken after 6 months? So after 6 months, there is a compensation in the LV. So LV end diastolic pressure will go down and there will be a separation of the aortic diastolic pressure and the LV end diastolic pressure because LV will start compensating. So now my next question is, what is AR index and what is the prognostic significance of the AR index? You all must be seeing a lot of TAVIs happening in your centers. So this is a sign of for periprosthetic aortic valve regurgitation. Okay, somebody has given a value of 25. So less than 25 or more than 25? Very good. So you are partially correct. So understand what is AR index. So here is that what we seen in the previous trace, the diastolic blood pressure is going down. In our previous case, the diastolic blood pressure and the LVEDP are almost equal. So as the diastolic blood pressure is going down, the more it goes down, more the diastolic pressure will go down, the more will be the severity of the AR. So AR index is diastolic blood pressure minus LVEDP divided by the systolic blood pressure into 100. So as the diastolic pressure will go down, this value will decrease. So AR index less than 25 as an increased mortality compared with the patients of AR index more than 25. So your value of 25 is correct, but you were saying that is more than 25. So AR index less than 25 is prognostically severe or prognostically bad. So in our previous case, this value becomes 0. The diastolic blood pressure in the LVEDP was almost 0. So this AR index is becoming 0. So 0 is almost very severe AR, almost free AR is occurring. So this thing is commonly asked in exam, what is AR index and what is the prognostic significance of the AR index. Remember this figure in mind, the formula and the prognostic significance. Very simple spot. Okay, so this the blue one is the aortic pressure trace, the red one is the LA pressure trace. So I have got some answers like mitral regurgitation. Now we have got some answer, MS with MR. The blue one is LV, sorry, the blue one is LV and the red one is aorta. Oh, red one is LA. Paresha has told MS, Vishal has told MS. So I have got three answers. So this is either MS or MR or MS plus MR. Now how to differentiate? Then only you will remember in exam. So there is a prominent A wave, the prominent V wave. So both A wave and V wave are prominent. There is clear-cut gradient in the diastole. The LA pressure is higher than the LV and diastolic pressure in the diastole. So clear-cut separation. So LA pressure in diastole is higher than the LV and diastolic pressure. So this is a classical of mitral stenosis. But as you are confused, why V wave is prominent? And normally also in LA, the V wave is higher than the A wave. In the earlier phase of the mitral stenosis, the A wave will try to compensate. The A wave will become more and more, but still it will remain lesser than the V waves. But in the later part of the mitral stenosis, the atrial contraction alone cannot overcome the stenosis. So initially the atrial contraction is trying to overcome the stenosis by increasing the A wave, but in the later part of the stenosis, the atrial contraction cannot take over the stenosis part. So the V wave will continue to rise. So in both mitral stenosis and mitral regurgitation, the V wave will be prominent. There will be a large V wave. Then how can you differentiate whether there is associated mitral regurgitation or not? That I am going to teach you. So in mild mitral stenosis, A wave will be taller. As the stenosis severity increases, the atrial contraction will not be able to compensate. The V wave will become continuous to be taller and taller. So tall V wave and LA pressure can be because of the MR or severe MS. How to differentiate? How to differentiate is, this is the tall V wave, but the VY descent. This is the peak of the V wave, this is the Y descent. The VY descent is slow. If the Vy descent is slow, then this Vy descent is because of the mitral stenosis. There is significant obstruction and the Vy descent is slow. But if the Vy descent is very rapid, see the Vy descent here, this is the slow Vy descent. Now see the Vy descent here. It is almost parallel to the aortic trace or LV trace. It is almost parallel to the LV trace. So if it is going almost parallel to the LV trace and it is very steep Vy descent indicates this is a severe mitral regurgitation V wave. Here it is indicating it is the V wave because of the mitral stenosis. So you have to remember, you have to look at the Vy descent. If the Vy descent is gradual, it is not steep, it is slow, then it is all because of the severe mitral stenosis. MR, significant MR is not associated there. But if the Vy descent is very rapid, very steep, then it is because of the severe mitral regurgitation. There is not any significant mitral stenosis. In both the cases, the V wave will be taller than the A wave. A wave will also be tall. The mean LA pressure will be elevated. Everything else will be same. The only clue is the rapid or the shallow Vy descent. I hope I am clear. Is there any confusion you can ask? Okay. So you have to interpret this LV trace before and after the ASD device closure. What has happened? So this is the LV pressure trace. The initial trace is before the ASD close, before the ASD closure. This is after the ASD closure. So what has happened? Okay, increase in LVDP. Why the LVDP is increased? Okay, so I've got the correct answer in the chat box. So you have to answer. This indicates the restrictive physiology of the LV. So LV restrictive physiology. LV restrictive physiology can be because of either the elderly patient, the patient of 60 years, 70 years, which are not detected in a younger age coming to the ASD device closure, concomitant hypertension, diabetic cardiomyopathy, or coronary artery disease. Now, again, my next question is, can you identify which patient is going to have a LV restrictive physiology on the basis of this? Can you predict this complication? So carefully look at the LV and diastolic pressure. So out of these three arrows, here the LV and diastolic pressure is the highest. It is almost 12 mm of Hg. That is, it is the upper limit of normal. So if you encounter any patient who is having the upper limit of normal of the LV and diastolic pressure, 12, 11, 13, 14, what we usually do in our cath lab or what we ignore is we take the lower one to satisfy ourselves. Okay, it is looking like 8 here. Let's take this one. This patient is doing okay. Take this one. Take this one. So first rule is always take the highest pressure. if your highest pressure is at the upper limit of normal. In a normal patient, when you have not closed the ASD, this LVEDP is transmitted to LA pressure. LVEDP is equal to the LA mean. LA mean is being transmitted to the RA mean because there is a large ASD. So RA pressure, LA pressure, and the LV and diastolic pressure all will be 12. In other words, even if you have not entered into the LV, you are just measuring the RA pressure and your RA pressure is more than 8. It is RA pressure mean is coming 8, 9, 10, 11, 12. Just think that your LVEDP will be high and that is LVEDP is getting transmitted via LA, via ASD to RA. So if you are getting mean RA pressure more than 8 or you are getting a LVEDP of 12, around 12 or more than 12, think 10 times before closing the ASD. What you can do is you just balloon occlude it or put your device, wait for a few minutes, again check the LVDP before releasing the device. Do not release the device if the LVDP is increasing. So even before putting the device, your baseline LVDP or your baseline RA pressure more than 8 can indicate you that this is a troubling water ahead. Do not jump in it. Okay, because all of you will start doing ASD in your life. ASD is a simple procedure. You may jump that, okay, this is looking good, 60-year-old lady, nobody has closed it, let me close this ASD. But think 10 times if the LVDP is at the upper limit of normal. Okay, identify the classical sign. Okay, I got one correct answer. This is the Carabello sign of critical AS. Caravello is different sign. Carabello B is different. Carvello's is different. Carvello sign is increase in the tricuspid regurgitation murmur because of the during inspiration. That is Carvello sign. Carabello sign is in critical AS during the when we pull our catheter. Because of the catheter, there is a increased obstruction, and as soon as the catheter is pulled, the increase in the femoral artery pressure by more than 5 mm of Hg. So now we don't see this sign often because now we are not using 8 French, 9 French catheters or 7 French catheters. For this, the valve area has to be less than 0.7 square centimeters. The pressure increase should be more than 5 mm Hg after the pullback. And usually now we don't see this sign. Initially it was commonly seen, but some examiners might show you in this sign because it is of historical importance. Okay, identify the procedure. Identify this trace, then identify what procedure has been done. Okay, this is the aortic pressure trace. Something was done, and after that the aortic pressure became like this. So what you can see here, Okay, so Arvind has given a correct answer. This is the pulsus paradoxus. So this patient is having, you can see here the aortic systolic pressure, the marked decrease in the aortic systolic pressure. So this is the patient is in pulsus paradoxus. So pulsus paradoxus is seen in the large pericardial effusion or the cardiac tamponade. And pericardiocentesis was done, and after the pericardiocentesis, the aortic pressure improves. And this blue pressure indicate, the blue trace is indicating the intrapericardial pressures. So here the intrapericardial pressure and the RA pressure. Here in the box it is showing the RA pressure trace and the intrapericardial pressure trace. So almost both are equal, and there is a loss of waveforms in this. After the pericardiocentesis, the intrapericardial pressures came down and the aortic pressures improves. So if you see a trace where the aortic pressures are very low, and after a procedure the aortic pressure improve, most of the times this is the pericardiocentesis trace the examiner is showing you. Okay, identify the trace again. I have labeled for your convenience. Okay, so you have to remember prominent X descent but absent Y descent. So when the Y descent is absent, this has to be a cardiac tamponade. Loss of Y descent or a flat Y descent is indicative of cardiac tamponade, because the increased intracardial pressure is not allowing the Y descent, is not allowing the RA pressure to come down. So this other trace is of the pericardial pressure trace. You can see the second line is of the pericardial pressure trace. Okay, so somebody has written in the chat box to show the explanations also. So the previous explanation, I think he wants to know. So in the previous trace, there are three traces, A, B, and C. In the A, we are seeing the pulsus paradoxus. In the B, we are seeing the raised RA pressure and the raised pericardial pressure, both are matching. The increased or the normal aortic pressure with the decreased intrapericardial pressure. Now going to the terminologies. In the A, it is showing the arterial pressure trace before pericardial synthesis, showing the typical paradoxus. The RA pressure trace and the pericardial pressure trace showing elevated pressures with the blunting of waveform. There are no clear-cut waveforms. Both are almost equal. After the pericardiocentesis, there is resolution of the pulsus paradoxus. There is reduction of the RA pressure and the reduction of the intrapericardial pressures. Explaining this trace again, here is the absent of the Y descent, and once the pericardiocentesis was done, look at these traces. The waveforms are blunted. You cannot see any Y descent here. So you cannot see any Y descent here, and here you can clearly see the Y descent. So somebody has asked how to identify the tamponade if it is not labeled. So look at this is the P wave. The wave which is occurring after the P wave will be the A wave. So there is a good A wave. The descent which is occurring after the A wave will be the X descent. This is the T wave here. the positive wave which is just occurring after the T wave will be the V wave. And you cannot see any descent here. Don't see any descent. Just after the V wave, almost flat like thing, and the A wave is coming again. Look here in a normal form, then again look at the left form. So here it is the P wave. Just after the P wave, this is a prominent positive wave is coming, that is the A wave. Then there is a descent that is called the X descent. This is the T wave occurring. Just after the T wave, a prominent V wave, and a prominent V wave will be followed by a Y descent. Here there will not be any Y descent. So you have to look just after the T wave. After the T wave, there will be a positive wave, V wave, and after a positive wave, if a descent is absent, then it is an absent Y descent, and that is indicating cardiac tamponade. And if one more trace is given you in exam, two traces are coinciding, and the other trace is almost zigzag, you cannot identify anything, then that is the pericardial pressure trace. And these two traces will be almost equal in pressures. And after that procedures, these two traces will separate out. The pericardial pressure will become zero, and in the inspiration will become sub-zero, and you can see clear cut Y descent. So this is after the pericardiocentesis. I hope I am clear. You have to look these traces again and again. You have to practice, then you will be master in these traces. Okay, interpret the RA pressure trace. So here I have not labeled it. Okay, you have given the diagnosis. So first, start from the beginning. Look at the P wave. So the positive wave which is coming after the P wave will be the prominent A wave. So this will be the X descent. Look at the T wave. So the just after the T wave, this small wave is coming. This will be the V wave, and this will be the Y descent. Because in your exam, they may ask you to label these waves. They can give you this trace on paper and may ask you to point out which is the A wave, which is the V wave. You might have mugged it up, and you will just looking this trace. This you can say this is a prominent Y descent. Here may be a Frederick sign. This is a prominent X, prominent Y descent. This is a constrictive pericarditis. So before mugging up, first try to identify the waves. So as I already said, this is the P wave. So just after the P wave, the positive wave which is coming is will be the A wave. The, the descent which follows the A wave will be the X descent. Then there will be a T wave. The positive wave just following the T wave will be the V wave, and the descent which follows that V wave will be the Y descent. C wave you may or may not see. So you have to just identify A wave, X descent, V wave, Y descent. So in this case, there is a prominent X descent, prominent Y descent. It's indicated of constrictive pericarditis, may be seen in RV failure also. So now coming here again, interpret the RA pressure trace. So here intermittently you are seeing the prominent Y descent. Although Y descent is prominent, but intermittently it is very prominent. So why it is intermittently very prominent? So first look, this is the T wave. The positive wave after the T wave will be the V wave. The descent which follows the V wave will be the Y descent. There is a prominent intermittent Y descent because of the respiratory variation, that is Carvalho's sign or Carvalho's phenomena, increase in the tricuspid regurgitation. Because of increased tricuspid regurgitation during the inspiration, we can see the prominent Y descent. Can be seen in right ventricular failure or severe tricuspid regurgitation. So just to summarize, large V wave, large Y descent can be seen in severe tricuspid regurgitation or RV failure. Deep X and deep Y descent can be seen in constructive pericarditis, can be seen in restrictive cardiomyopathy, can be seen in severe RV dilatation, severe tricuspid regurgitation, especially deep Y descents may be seen in severe RV dilatation or severe TI. But you have to remember, if you don't see a prominent Y descent, a flat Y you can see, the diagnosis is tamponade. So you can see all these three traces in your exam: tamponade, constructive pericarditis, and RV failure, so showing the Frederick sign or prominent Y descent. Little bit difficult. You have to identify which chamber trace is this. So we have got all three answers: PA, RV, RA. Okay, all four answers I have got: RA, RV, PA, and PCWP. Okay, how to identify it? So going back to this figure, which I have inserted in my first slide of introduction, again to summarize, the LV and the aortic or the PA pressure trace, the peaking occurs between the peak of the R wave and before the T wave. Here the peaking is occurring in the between the peak of the R wave and before the T wave. So here the peaking is occurring, and in the atrial pressure trace or the pulmonary capillary wedge pressure tracing, the positive waves are occurring either before the R wave or just after the T wave. So there is no peaking of any atrial pressure trace during the ST segment. In the ST segment, there is no peaking of the atrial pressure trace. However, the peaking of the arterial pressure trace, be it aorta, be it PA, be it RV, be it LV, all happens during the ST segment. Now go back. So here there is the R wave or the S wave. Here it is the T wave. So in this square, the atrial and the ventricle, the arterial or the PA or the aorta or the RV or the LV, all should be peaking in this segment. This ST segment, it should be peaking. But where it is peaking? It is peaking after the T wave. So if the pressure is peaking after the T wave, it cannot be LV, it cannot be RV, it cannot be aorta, it cannot be PA. For example, here where this is the pulmonary artery pressure. So the pulmonary artery pressure, one more thing I will tell you later. So where it is peaking just, it is after the T wave it is peaking. Second thing is you have to see where, how is the downstroke of this wave. So it is very rapid. It is very rapid. And this is the PA pressure trace. How is the downstroke of this pressure? It is slow. It is slow downstroke. So if the pressure is peaking after the T wave and the downstroke is very rapid, then it is a atrial pressure trace. So this is the prominent V wave of the PCWP. So this is not the RV pressure trace. This is not the PA pressure trace. This is not the RA pressure trace. This is the pulmonary capillary wedge pressure trace showing the very, very prominent V wave because of the severe mitral regurgitation. How to differentiate large V waves from a PA pressure? So V waves peak after the T waves, whereas the PA systolic pressure peaks during the T wave or during the ST segment. The V wave has a gradual upslope and a sharp downslope. However, the PA pressures have a gradual downslope. Okay, you have to remember these two main points. The V wave peaks after the T wave. However, the PA pressure peaks during the ST segment or may peak during the T wave, but never after the T wave. There is a gradual upslope and sharp downslope in the V wave, and there is a gradual downslope in the PA pressure. Now identify this pressure trace. So you are telling it is aortic stenosis. Why in aortic stenosis you will be having the aortic diastolic pressures will be equal to the LV and diastolic pressures. So first you have to identify the traces. So first of all, this is a over-damped trace. The over-damped trace, we are seeing the blunted waveforms. The waveforms are not very sharp. So this is an over-damped trace. One thing you have to tell in the exam. If you are seeing very peaked pressure, this is under-damped. If you are seeing very rounded contours, this is a over-damped trace. Second, this is the LV pressure trace. And why this is not aorta? So although this can be aortic trace, but diastolic pressure cannot match the LV and diastolic pressures. So this is not aorta. This is the LV pressure. This is the LA pressures. Now tell me what is the diagnosis? The green one is the LV pressure and the yellow one is the LA pressure. Second thing, why it is not aorta? I've already told you in this figure. Both LV and aorta will peak at the same time. Where the it, atrial pressure will peak just at end, the end of the systole it will peak. So now carefully look again. So had it been the aortic pressure trace, this peaking will be occurring here simultaneously with the LV peaking. So this is not the aortic pressure trace. Now you can clearly see this is peaking with the T wave. This is peaking after the T wave. So this is the atrial pressure trace. And this is the prominent V wave of the LA pressure, and this is because of the severe mitral regurgitation. Acute severe mitral regurgitation, the atrial pressure trace showing a prominent V wave, and this patient is really sick. Pressures are borderline 100 systolic pressure, patient is having tachycardia, large V waves is there. Although the pressures are overdamped, so you cannot see any A wave here. So only prominent V waves being seen. So just remember, both arterial and LV pressure trace will peak simultaneously at or around the T wave. The prominent V wave will not peak at the LV or aortic pressure. They will peak later and will be peak after the T wave. So this is the best way to identify the V wave from the PA pressure trace or the aortic pressure trace. So somebody is saying in AS there will be late peaking. So AS there will be late peaking, but not will be in the later half of the end of 1/3 of this. Here the diastole is happening. Here it is peaking. So aortic pressure will trace will not peak here. So going back to the slide. So where it has peaked? It is peaked here, not peaked here. Even in the HCM, where it is peaked here, where it is peaked. Although in the mid to late systole it is peaked, but is not peaking here. Now go back to that slide. Where it is peaking? It is peaking here. If it is peaking here, it can be severe, yes. So you may confuse with this, but look at the other features also. Why this diastolic equalization? Aortic diastolic pressure cannot be equal to this. So you have to take account of all the things. Then whether it is a LA pressure trace or it is a aortic pressure trace, you have to look all these things in combination. Then only you will be able to come at the right answer. So tell me one answer, why the V wave is taller in LA than in RA? Why even in normal patient? Compliance. Why? Pulmonary vein. So left atrium is caged. So LA is less compliant compared to RA. So LA is non-compliant or less compliant compared to RA. That's why the LA pressure is more, in the V wave is more compared to the RA. I hope we will take this last slide, or can we stop? It is more than 7:30.
Dr. Ankit, I think we can do this one.
Okay.
But we are on the flow. How many, by the way, you have left?
So probably I have made more than 20. We can
More than
continue some
20.
next time.
So
And other,
yes, that's what I was thinking. I mean, your this thing is very tempting. We have huge, number of people, and I mean our dear students. So maybe we'll continue this one. This one we'll do, and we will have one more with your help and all. One more similar one. Okay.
okay, sir.
Continue, please. Very informative letter. People are saying so. I mean, now you have no choice. You have to say yes.
Okay,
And
okay, sir.
in front of, if you say yes in front of 100 people, then, I have so much of evidence over here that you have said yes. Okay, let's continue, Dr. Ankit. Please. Thanks a lot. Please.
Okay, sir. Thank you, sir. So interpret the hemodynamic trace post TAVI. So a lot of things are happening here. I have, for your ease, I have labeled some arrows. You have to identify what is happening here. Okay. So one thing you can clearly see, this is the aortic pressure trace. So aortic pressure trace here, the pressures are going down and here the pressures are coming back to normal. In the CVP trace or the RA pressure trace, here you can see some prominent waves which are prominent in this phase where the arterial pressure is going down. So what is happening? Here you can see a P wave followed by QRS, P wave followed by QRS, P wave followed by QRS, P wave followed by QRS. Here you cannot see any P wave. So here the AV dissociation is occurring, and here you are seeing the Canon A waves because of the AV dissociation. Because of the ventricular pacing, the AV dissociation is occurring, and there is, because of this loss of atrial kick, the aortic pressures are going down. And once the AV conduction resumes, P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS, the atrial pressures are going back and the Canon waves have disappeared. So these are intermittent Canon A waves because of the RV pacing, because of the complete heart block occurring after the TAVI, and because of the loss of the AV compliance. Here the aortic pressures is going down and intermittent Canon A waves you are seeing. Now somebody has to type what is the mechanism of the Canon A waves. Why the Canon A waves are occurring. So it is the atrial contraction occurring against the closed AV valve. So RV is also contracting, the tricuspid valve is closed, and the AV valve, the atria is contracting against the closed AV valve, closed tricuspid valve. So you have to say that the right atrium is contracting against the closed AV valve while the RV is also contracting. So this is the mechanism of the Canon A waves. So you can get the regular Canon A waves in the junctional tachycardia, intermittent Canon A waves during the right ventricular pacing or the complete heart block. Again, the same mechanism, what I have told you, intermittent cannon A waves and the smaller pulse pressure because of the lack of AV synchronization. So what is the abnormality here? Okay, let me explain this trace to you. So this is the PA pressure. So PA pressure here is very low. So how we measure PA pressure? We go from RA to RV, we cross the pulmonary valve and we enter our catheter, end hole catheter into the PA. So where our end hole is looking, our end hole is looking away from the pulmonary valve. So this is an artifact. So it's an end hole artifact. When our end hole catheter is looking away from the obstruction, we will get a very low pressure. That's why we are getting a PA pressure of very low. The mean pressure is around 5-6 mmHg. We are getting a very low PA pressure because our catheter is looking away from the obstruction. So although because of the obstruction, very less flow is coming into the PA, and even our catheter is looking away in the direction of that flow. Current is flowing in the towards PA and our catheter is looking away from the pulmonary valve. That's why we are getting a very low pressure. And once we are pulling from this PA, this pressure is becoming even lower. Why this pressure is becoming even lower? And then once we go into the right ventricle, this pressure becomes very high, almost 80 to 100 mmHg. So one thing I have told you, so this is one end hole artifact. When the end hole catheter is looking away from the obstruction, the pressures will be very low. Second thing is happening here is, this is called the Venturi effect. This is not pressure recovery. Pressure recovery is a different thing. So what is the Venturi effect is, when the area decreases, this fluid is flowing. So this this is suppose RV, this is suppose PA, and this is the pulmonary valve. Here is the constriction in the pulmonary valve. We are putting our catheter here. So our catheter is here. Since our catheter is looking away from the direction of the blood flow, so here it will record a very low pressure. Once we are pulling our catheter back into the pulmonary wall, here there is a critical narrowing, and as the area is decreasing, the pressure decreasing even further here. And this is causing the Venturi effect. And once we come back into the RV, the pressure increases. Now, one very practical tip for all of you. You tell me you are doing angiogram with a 5 French Tiger catheter or with a 7 French Judkins guide, and which catheter has more chances to suck in air, 5 French catheter or a 7 French catheter? So 5 French catheter. This is again because of the Venturi effect. So once you take out your guide wire or your angiography 035 wire out of the your catheter with a speed, this narrow 5 French area will have a low pressure. Once the wire is removed from this area, this will be having a low pressure. And this, because of the low pressure, it will suck in air rapidly. But this will be a 7 French catheter. Once you take out your wire from this catheter, this will not have so low pressure that it will suck in a lot of air. So smaller French catheter will suck more air once you take anything inside or once you take anything outside. That's why whenever you are doing any angioplasty or any angiography with a 5 French catheter, you are rapidly taking your wires, balloons, anything out. You are rapidly taking your system inside or outside. Always de-air cautiously because it is very prone to take air, suck in air because of this Venturi phenomena. So Venturi phenomena is very important cardiology. You go and read where all you can apply Venturi phenomena in your cardiology. Venturi phenomena is important for your all vegetation, where the vegetation is getting deposited in your heart, why the aortic wall prolapse occurs, why SAM occurs. Everything is explained by the Venturi effect. So with your kind permission, can we stop here?
But Dr. Ankit, I think we have to stop.
Because
And
our time is
because
overdosing from the
45 is the final, cutoff sort of. So we have reached that one. So thanks a lot. People are saying so. Next class we will schedule in in one and a half months time. Meanwhile, I mean, kindly prepare more of them. Thank you so much. I mean, it was wonderful, believe me. Reason being that this is a complex area and people shy away from reading about it. And as Dr. Ankit so nicely said, you have to go and read. Then you will be able to understand next time this thing. We cannot have a class on Saturday. Somebody is saying Saturday is not possible because this is fixed timing of Tuesday. The timings and the days cannot be changed. So practice exams near. So please schedule practice exam. What is practice exam? They have some practice exam, it seems, which is best book to understand. So they are saying which is best book to understand hemodynamics.
So Morton Kern handbook is there. It is freely downloadable from LibGen. You can all download Morton